Hi, my name is Jalitta Aickareth, a third-year pharmacy candidate from Florida A&M University. Today I'll be going over a journal club which compares the effectiveness of clindamycin versus trimethoprim sulfamethoxazole in uncomplicated skin infections. Both clindamycin and trimethoprim sulfamethoxazole, they're both relatively cheap when compared to other antimicrobials. Therefore, it is common for them to be used as empiric therapy. Now, this study evaluates whether one drug is more effective than the other in curing uncomplicated skin infections, and the study was funded by Pfizer and took place in the United States. It consisted of a 10-day treatment regimen followed by a 1-month follow-up, and the study ran from May 2009 through August 2011. In the study, patients were recruited at 4 locations. It was the University of Chicago Medical Center, the San Francisco General Hospital, the University of California Los Angeles Medical Center, and the Vanderbilt University Medical Center in Nashville. And the patients were collected from urgent care clinics, emergency departments, and affiliated clinics. These locations were chosen based on the incidence of uncomplicated skin infections. Now, informed consent was obtained from the participants as well as the legal guardians of the children that participated in this study. And the patients were categorized based on the presence of cellulitis, abscess, or both. Prior to randomization, patients were stratified into 2 groups based on their clinical manifestation. The larger abscess cellulitis group or the smaller abscess limited abscess group. So these were the 2 groups that they had. Patients who had a single abscess with a diameter up to 5 centimeters or less than 3 centimeters in patients 6 to 11 months of age and less than 4 centimeters in patients 1 to 8 years of age were grouped into the limited abscess group or the small abscess group. And then all the other patients, including those with an abscess greater than 5 centimeters, or a patient with 2 or more sites of skin infection, and patients with cellulitis were grouped into the large abscess or the cellulitis group. So prior to beginning the study plan has specified that limited abscess group and the larger abscess cellulitis group be analyzed separately because the way the treatment was assigned was different. But in this study, we will only be looking at the results for the larger abscess or cellulitis group only. So the patients were randomly assigned to receive either clindamycin or trimethoprim sulfamethoxazole. Half of the patients received the clindamycin and then the other half received the trimethoprim sulfamethoxazole. There were a total of 524 patients that was enrolled in this study, and out of the 524 patients, 264 received the clindamycin treatment and 260 received the trimethoprim sulfamethoxazole treatment. The clindamycin was given as a 2 150 milligram tablets 3 times a day, and the trimethoprim sulfamethoxazole was given at doses of 160 milligrams of trimethoprim and 800 milligrams of sulfamethoxazole, which is administered as a 2 single-strength tablets twice daily. And then the patients were assigned to receive trimethoprim sulfamethoxazole were given 2 placebo pills for the midday dose. The pediatric doses were adjusted according to their body weight of the patient. Now there were inclusion and exclusion criteria. The inclusion criteria included 2 or more of the following symptoms for greater than 24 hours, and those symptoms are erythema, swelling or induration, local warmth, purulent drainage, and tenderness to pain or palpation. Also, if you have abscess or cellulitis or abscess and cellulitis, you can be included into this study. Now, some of the inclusion criteria include superficial skin infections, like impetigo, skin infections at a body site that require specialized management, such as the genital or hand infection, human or animal bite at the infectious site, a high fever, so an oral temperature greater than 38 degrees Celsius in children, some immunosuppressive medications if you're taking any of those, if you have any immunocompromising conditions such as diabetes or chronic renal failure, any morbid obesity, surgical site or prosthetic device infection, if you have received of an antibacterial therapy with anti-staphylococcal activity in the last 14 days, if you lived in a long-term care facility, or if you had cancer or an inflammatory disorder that required treatment in the past 12 months, or if you had any major surgery in the last 12 months, then you cannot be included into the study. Again, the study focuses on uncomplicated skin diseases, so if you have any of these listed criteria, you would not be included in this study. Okay, so the primary endpoint is defined as the improved cure rate of the uncomplicated skin infections, and the secondary endpoint would be defined as the cure rates at the end of the treatment at the 1-month follow-up visit and decreased adverse effects. In this study, like I said, there were 524 patients were enrolled. Out of the 524 patients, 264 received the clindamycin treatment, 260 received the trimethoprim sulfamethoxazole treatment. 52.3% of the population was male, so about half, 53.2% was black, 40.3% was white, 28.6% was Hispanic. The mean age was 27.1 years, and 29.6% of the patients were actually children, so that was actually something different in this study. It actually had children involved. Okay, now coming to our results. So the patients who received the clindamycin as compared to those who received the trimethoprim sulfamethoxazole did not have a significantly greater reduction in the cure of infection or any reduced ADRs. The rate of cure in the intention to treat population, or the 524 patients, was 80.3 in clindamycin group and 77.7 in the trimethoprim sulfamethoxazole group. But it's very insignificant. In the population that could be evaluated, the rate of cure was 89.5% in clindamycin group and 88.2% in the trimethoprim sulfamethoxazole group. So there was really no significant difference between the treatment groups in either the intention to treat population or the population that could be evaluated. There was no significant differences between the ADRs as well. When you go into the secondary endpoint, you'll notice that the cure rate at the 1-month follow-up visit were similar for the clindamycin and trimethoprim sulfamethoxazole group, and then it was the same that could be evaluated for the ADRs as well. The rate of study discontinuation due to adverse events were similar in two groups, like I said before. And luckily, there were no treatment-associated serious adverse effects that occurred in this either. And then the most common adverse effects seen were diarrhea, nausea, vomiting, pruritus, and rash. Going over the strengths and weaknesses of the study, some of the strengths that I've seen is that the outpatient population was used in the study, so it could be used to generalize for the large population, even though only 524 patients were involved in this study. Also, this study was a double-blind, randomized clinical trial, so neither the patient nor the administrator of the drug was aware of who was getting what, and therefore bias was reduced. Both adults and children were included, so we got to see both sides in the study, and half of the population was male and the other half was female. Also, the study was geographically diverse because there were patients from 4 different locations in the United States that came together for this study. Also, some weaknesses or some flaws in the study that I saw was patients with serious coexisting conditions were excluded. Also, this study shows a 1-month follow-up, and that may not be adequate because reoccurring infections may be present, especially with staph, MRSA. So 1 month may not be adequate enough. It could be longer. Also, the minority populations such as Asians, Middle Eastern descent are not included in this study. So overall, the study compared the effectiveness of clindamycin and trimethoprim sulfamethoxazole in uncomplicated skin infections. So both drugs are used for empiric treatment of uncomplicated skin infections due to its cheap price and efficacy. This study hypothesized that clindamycin and trimethoprim sulfamethoxazole would have equal rates of cure, and it proved to be true. And this study proved to show that there is no clinical significance that one drug is more effective than the other. Also, the ADRs for both medications proved to be similar. And that's it. Thank you.